Thank you very much, Fran, and good afternoon to all of you. I'm glad that both of you are now, both Fran and Maria spoke very fast, so I'm going to try and match their speed so I can get through my presentation. So in essence, what Sharon and Fran asked us to do is to identify the types of action that have been taken to address health inequity, the forms of governance that have helped to pursue a more health equity agenda, and what are some of the challenges and opportunities. And I've been asked to speak specifically from the South African perspective. So I'm going to start with the background and context, and just to note that it's no-brainer, but some people might still be confused about where South Africa is. So as the name implies, it's right at the southern tip of Africa. We have around 56 million people in the country. We had democratic transition in 1994. We classified as a middle-income country, and we have a rights-based constitution. So South Africa remains one of the most unequal societies in the world. On this graph, you can see that Russia tops that list. What this graph does is to look at the 1%, what proportion of the wealth of any country is held by the 1% of the wealthiest people. And you can see that South Africa is among the top 10, which is certainly not a position that I think any country should be in, with Russia topping the list. So just more information on the inequity is our Gini coefficient is 63.4. The markers of those inequities continue to be race or ethnic group, gender, geographical distribution, and public and private health sectors. And what makes things even more complicated is that we have a very complex and heavy burden of disease. So this just shows you the geographical inequities in the average household income. US dollars is roughly 13 Rand. And in the Western Cape, which is a very urban province, you can see the average household income for the country as a whole is just around almost close to 200,000. In contrast, in the Western Cape, it's much higher compared to Limpopo province, which is a much more rural province. Those inequities are also seen in average household income when you look at it according to gender. So men earn a lot more money compared to women, which of course is not surprising, but still certainly a very disconcerting figure. And so you can see in 2015, male-headed household earn significantly more compared to female-headed households. Our life expectancy, the gains in health similarly show quite a wide variation. The lowest life expectancy, I've just taken the one for women, it's around 58 in the Free State compared to 69 in the Western Cape province, which is both urban and with a lot of wealthy people. Causes of death, just by way of context, a complex burden that consists of communicable diseases, non-communicable diseases, and injuries that take a heavy toll on the lives of South Africans. And similarly, you can see just by looking at the bars, the sort of inequities in the causes of death by province for the year 2014. So what's been some of the action that's been taken? So there's some good things that have happened, and certainly has been largely because of a hard-won democracy in South Africa. Some of the progress is that a couple of years ago, a few years ago, we agreed to what's called the National Development Plan, which sets out a broad roadmap for eradicating poverty, addressing unemployment, which is very high in South Africa, depending on which figures you use, but on average it's around 26% unemployment, and the huge inequalities which I've just demonstrated. There's been significant investment in the social sectors, health, education, and social development, and certainly in terms of government spending, those social sectors take quite a significant proportion of social spending. There's also been some bold steps to improve overall population health, and these are what make us very proud to actually look at what are some of the structural determinants of health. So similar to the experiences of Uruguay that was mentioned this morning, we have very good tobacco control legislation, which again has been through the action of civil society, combination of government and civil society working together. South Africa last year became the first country in sub-Saharan Africa with its new salt regulations, which actually regulates the salt in processed food and bread, which is a staple food for many South Africans. And so industry had to meet certain targets by July 2016, and the remainder, a further reduction in the salt in processed food and bread must come into effect in 2018, July 2018. Last year, if I had given this talk a year ago, I would have told you that by April this year, we will implement a 20% tax on sugar-sweetened beverages. The Minister of Finance announced it last year, but the industry went in overdrive in their advertising, and so there's been some backtracking on the sugar-sweetened beverage tax, and they're now talking about a 11% health promotion tax. And we've just, comments were open until last Friday, so I was one of the people to sign a petition to ask the Treasury to reconsider the introduction of the full 20% of a sugar-sweetened beverage tax. And there's also been a series of health sector reforms. As I've said already, there's been increased access to health and education services, with the antiretroviral treatment program making a big difference in turning around the decrease in life expectancy that we've seen, particularly in the early 20,000s. I was very interested to hear about the proposed basic income grant that will be introduced both in Finland and possibly in India, but South Africa has the largest social grant assistance program. Some people have also lobbied for a basic income grant, but all children under the age of 18, if they're below a certain income, and older people over the age of 60 years receive a grant. So in terms of governance, I was wondering, Fran, what I was going to say about governance, especially after the development since I've left the country. But probably one of the most important aspects of governance has been the legal instrument that's provided by our Constitution. So Section 27 of the Constitution contains the Bill of Rights, which defines both basic rights such as the right to dignity, as well as a series of socioeconomic rights such as the right to reproductive health care, for children, basic health care, and that no one is allowed to be denied any access to emergency services. Leadership, all that I can say is that it's been a mixed picture, and it's ranged from exemplary, such as what the previous public protector provided, to frankly shocking. There's been very strong civil society organizations and demands for accountability. It initially started around the HIV epidemic, and it's since been expanded to other areas. And Section 27, which used to be the old AIDS Law Project, has now renamed themselves to Section 27 in reference to the Constitution, and they've taken up a range of social issues, including the failure of the Limpopo government to provide textbooks about 3 years ago, and increasingly also when there are shortages of essential medication in clinics. We have a very vibrant media, and that always helps in terms of governance and action around the social determinants of health. And increasingly, communities are rising but less so around health equity. It's mostly been around service delivery and the failure of many municipalities to meet basic needs around whether it's water, sanitation, refuse removal, etc. So what have been some of the challenges? Among the top of that, I think it's probably a universal one. It's always that there's suboptimal leadership and governance. In the case of South Africa, there's been a complex set of relationships among the three spheres of government: national, province, and local government, and that has often bedeviled good action. I also think there's been insufficient recognition of that much more needs to be done in terms of intersectoral action, particularly around the social determinants of health. Many times we've had laudable policies, but implementation, they haven't necessarily translated into implementation. So what we've called implementation inertia. There's been an underinvestment in human resources for health and people management. Budgets and funding haven't always been commensurate with the policies that we put out. And then just overall difficulties of managing transformation and insufficient monitoring and evaluation, which was one of the recommendations contained in the Commission on Social Determinants of Health. However, what are some of in my last 2 minutes, what have been some of the opportunities? Many people, well, maybe not many people, but certainly some of you might know that at midnight on Thursday last week, President Zuma replaced a number of cabinet ministers, and that has led to an outcry. And so I've seen in the past weekend an unprecedented level of action across all sectors of society to actually say, let's look at, let's reclaim South Africa, but importantly, let's hold government accountable, and let's make sure that they actually stick with the values of the Constitution of equity and social justice. And then just 2 exciting opportunities, research and capacity building initiatives. One is called the Takano Institute for Health Equity, which is an initiative to build leadership capacity among civil society. So over time, it would lead to a catalytic force that would actually lead to change and greater health equity. And the second one is at my university, which is an endowment from one of its alumni, the late Professor Aubrey Shyam, and it's to establish a research program and a PhD scholarship program on social determinants of health and health equity. Thank you very much. I have 3 minutes to spare from my 15 minutes.
Thanks very much, Letitia, and especially bringing us right up to date with South African politics. It sounds very dynamic. Now, we've got 10 minutes for questions. I can hardly, if I do that, I can see you. So I think we've got roving mics. Yeah, I've got 2 colleagues who have very kindly agreed to come with mics. So if you'd like, there's one down the front here and one there. So perhaps one right down the front. Oh, no. Or Albert, if you go first, and then we'll bring it to the person at the front. Thank you. And just if people could say who they are, that would be great.
Okay, thank you. Thank you much for the 2 wonderful presentations. A particular question for Vina from South Africa. And I understand this is the top 10 thing you don't want to be the most unequal nation. But I noticed out of those emerging countries, the BRIC countries, Brazil, Russia, India, China, and South Africa, you stand the best out of those 5. So could you share with us some of the initiatives doing, especially very impressive, your increased access to education and health, and also some civil society movement. Maybe compare apple with apple, orange, orange. How you compare with the other 4 emerging countries out of this group, because they're actually the emerging world economy, but you actually perform the best. More positive. I would like to think more positively. In a way, you perform the best out of those 5 leading countries in the world. What particular tricks that South Africa has done that we could learn?
Although I think we're probably all equally bad in terms of inequality because we all fall in that top 10 list, my sense is that there needs to be that the discourse around inequity, I know certainly in South Africa, it's become relatively recent, but it's almost to some extent, government has had quite a defensive approach. So what they've done is when they've seen calculations of the Gini coefficient, they've often then looked at what they call the social wage and recalculated after social grants are included. And it does come down, but it still looks bad, because as we all know, the closer the figure is to 100, the more unequal the country is. So there's a recognition, but there almost seems to be a paralysis in government about what needs to be done. So on the one hand, there's that paralysis, but I think it's also a failure to acknowledge that it can't just be tinkering around the edges, that you have to look fundamentally about the way the economy is structured, about powerful interest groups, and about how you're going to address those, those interest groups.
Okay, thank you. Down the front here. Then I think I'll be able to take another couple of questions if people can put their hand up.
So my name is Stephanie Hewitt, and I have a special interest in the shortened life expectancy of mental health consumers around the world. In Australia, the life expectancy gaps are worse than our Indigenous peoples. My question, I'll start sort of with the Australian context because I know some of the Australian players. So my question is, how do we get individual health workers to be more politicised and to be more active in things like conferences and in daily life and daily practice? So Fran, thank you for standing up at the primary healthcare conference 18 months ago and having a go about private health insurance. And Cassandra, thank you for having a go on Q&A recently. But how do we get more of that stuff happening? And, whether it's Australia or globally, but how do we get some action and speaking up? Because I see too much sitting in chairs at conferences and not asking the questions and not going on the telly and all that stuff.
Okay, I might let Cassandra. Would you like to comment on that one? I mean, yeah.
I'd love to talk about private health insurance.
I thought you might. I mean, I could, but you.
Am I mic'd up?
I think so, yes.
Yeah, look, and I will touch on it a bit when I get to speak for a little longer. But I think it's a really great question. The recognition that whilst, for example, in Australia, by and large, people do not get shot in the streets for being vocal advocates, speaking up against government. The dynamics can be, the behaviours of governments, we believe, have led to a real chilling effect in terms of people's sense of safety about speaking up. And so I think it is through solidarity and being prepared to share that, to the peer support of that, and constantly pushing the boundaries of that, that we will build the confidence that ultimately people's voices will beat the power dynamic of the efforts of government to intimidate and silence. But we shouldn't underestimate, we know the powerful interests at play in this area. And so we accept that there is a role for peak bodies and for others to be the kind of front line in saying it's safe to say that the private health insurance rebate should be abolished. It doesn't work. And so that, as others are in more diplomatic environments, to see that some of those voices that are out the front saying with the strong voices, this system is not working, and to be constantly calling it out. But I'm happy to talk a bit more.
And for the international members in the audience, Australia currently spends about $35 billion a year subsidising for people to hold private health insurance, so hence this debate. Now, I think Maria wants to make a comment, and then I'll go to the person there. So, Maria.
Just very quickly, because I think it's one of the key questions that we need to address, because the moment we will mobilize again our own people and then the voices will be on the street, and that's the way to generate political pressure. Let me just to give you some minor examples on how things are changing. The streets of Beijing, they saw demonstrations, and it's not a country where demonstrations are very common, because of the air pollution. Citizens went out saying, I can't breathe. So this is one very good example of how things are changing. Now China has declared air pollution priority number 1 at the government. Then we saw many workers demonstrating in France on the issue of asbestos. Remember? That was extremely powerful. And I have to tell you that in Spain, after the economic crisis, for months, every day, health professionals were going into the street, demonstrating on something that it was called the white wave. So people, because they had a perception that they were losing their right to universal health coverage, which is something that in Spain people doesn't debate about it. So we need to gain again our own professionals to talk about health determinants and not just diseases, and reacting when there is Zika outbreak in Brazil. I will expect the Brazilians during the Zika outbreak to protest to the fact that they don't have access to sanitation, and that was the cause for having a Zika outbreak. But they were requesting more medical services, which was totally legitimate. But you need to understand, and sometimes our own people is the one that doesn't understand beyond the disease, and we need to educate them again on the health and the well-being more than the diseases.
Okay, in the middle.
Thank you. My name is Zygmunt Kazicki. I'm from the United States and University of Detroit. And you had mentioned something about keeping politicians accountable, which I think is an interesting concept. Yet how do you keep them accountable when the lobbying groups and the interest groups are much more powerful, and they can go directly to media and go over your head with advertisements and all kinds of public relation campaigns? And here's the second part of that. Throughout the United States, and I'm sure this is true around the world, we have public health departments in every community, but we don't energize any of them. They're passive. They lay back and wait. None of them are aggressive that I really can say. Where does the initiative start to get all of these different public health agencies who are already on the ground, who already have people who have an interest in this, engaged, working together? I mean, what is it going to take to mobilize this huge public health force? And as a gal in the front row pointed out, these conferences are nice. We know the obvious, but where is the mobilization? How do we do that? It's all yours.
Just before I hand over to Letitia, I have to say last week we had a Health in All Policies conference that Maria and I were at, and there was a wonderful young black physician from New York, Aletha Maybank, and she works for the New York City Health Department, and she was incredible as an advocate. And she made the point that I am so lucky that the Commissioner of Public Health enables me to do this advocacy as part of my work. And she was really inspiring, speaking about her role as director of a health equity strategy for the city of New York. So maybe, things are beginning to change there, I think. And I think the commissioner is a woman called Mary Bassett, who had a strong history working in Zimbabwe before that, presumably part of the liberation movement. But it's a great question, and Letitia, you might like to comment too.
So just following up on what Fran said. So firstly, I think it's we often, as a citizenry, don't make enough use of structures that are in place already, parliamentary structures. So Parliament is meant to hold the executive, to account, but there's often insufficient interaction, with those structures of Parliament. So if I have to take especially the academy, we don't necessarily build or lobby our democratically elected parliamentarians. So that's one avenue. The second one is maybe picking up from the comment that Fran made, is that we all assume that government is a monolith. But there are officials or people who are actually sympathetic to the cause, and sometimes they need encouragement also to pick up an issue. So it's also around how do we influence them. So that would be my first suggestion. The second one is through the media, that again actually giving the journalists that come for a comment to give them a slightly different perspective. I mean, I was asked recently for a comment of somebody that has a very rare form of cancer that's going to take more than $500,000 South African rand just for one course of treatment. And so this family had gone to the media to complain about the private health insurance that was unwilling to pay. She wanted to know from me whether the new national health insurance scheme would pay for it, and I said no. But then I spent almost an hour on the phone explaining to her why it would be unjust and inequitable to spend more than R500,000 rand on the treatment of one individual versus all the other things like providing free water and sanitation, immunization to children, in particularly who are poor and vulnerable. The third one, I think, is through civil society action, whether it's from the American Public Health Association in your case, but a broad coalition, that actually need to all ask for the same, thing. And the last one, I would say, is around a strategy that worked in Nicaragua very well, which is around each one, teach one. Is that also community members, we forget our position of privilege because we're educated and we come to these conferences. But we need to take the knowledge that we get and we need to educate the ordinary people, around some of the evidence and that will improve health and that would actually have long-term benefits.
Okay, thank you. We've got time for a couple more quick questions. There's one here and one over there. Thank you.
Thank you very much, people. And also Cassandra, good to see you and speaking out and speaking loud. My name's Hope Alexander and I'm a health consumer advocate and I come from Western Australia. And the mention about how do we make politicians accountable, we had a recent election in Western Australia, state election, and several of the parties came to have this talk, and I was the first to put my hand up because our then Minister of Health, thank God he's no longer the Minister of Health, was saying how we now have an oral health plan in Western Australia, rah, rah, rah. So I said, Minister, I'm so glad we have an oral health plan. Some of us have waited such a long, long time, and now, Minister, when are we going to have putting the head back on the body and putting oral health back with the general health? And nobody spoke. None of these 5 politicians had any comment. And the MC said, oh, we'll leave that like Q&A as a comment. But thank God that the Minister of Health is no longer, and the new one actually knows about health and all policies in Western Australia. So that's wonderful.
Thanks, Hope. And I think you made a great point that in Australia, you can almost tell someone's social class by their teeth these days because there really isn't good dental care for people on low incomes. Cassandra, do you want to add anything to that? Or just...
Look, on the issue of making politicians accountable, of course there are a number of things which is essentially about, the sort of the culture, the political culture in which we operate. But I do want to highlight, for example, in the Australian context, we have had a series of changes which have absolutely hidden the true story. For example, in our budget now, 3 years ago, the government stripped out any of the distributional impact assessment from the federal budget. The academics in the room will have a much, clearer eye on this, but we've had, for example, removal of sort of data collection associated with Aboriginal and Torres Strait Islander outcomes because of the impacts on the ABS. So there are a lot of these, they're small chips, but collectively they actually do mean that we've got a real reducing of the institutional capacity to be able to call governments to account. And so I don't want us to lose the fact that there are some of these barriers for us which we've got to rebuild systems when the politicians are very deliberately, we believe, in a range of different ways, hiding some of the knowledge that we need to be able to call out, what is going on in terms of budget and economic policy.
Great, thanks. That's probably Jim, a quick one.
I'm Jim Hyde. Is this working? Yeah. I'm Jim Hyde from Victoria. and I'm a sort of a public health has-been these days. But one of the things that I think we need to do is to reconsider the structural barriers that neoliberalism has introduced, because as a senior public servant, which I have been, I've been Director of Public Health in this state and Director of Primary Health Care in New South Wales, you know, I couldn't say anything publicly at all. I was known as a very bad, radical public servant because I kept on giving bad advice to ministers, e.g. I didn't say, let's build more hospitals. I'd said, let's close more hospitals and redirect the money. But nobody ever stood up and supported me, and I was saying that. I then ended up in the College of Physicians, where I tried to lead social determinants statements, but you know, I never really got great traction, and neither does people like Fran, who should have been a celebrity, and Cassandra should be a celebrity now. You know, they should be the Kardashians of public health, but they're not, because we do not, as a public health community, actually get in behind the people that are putting the, you know, there are barriers about any of us speaking out. And the barriers are, you're a senior public servant, you're not allowed to say anything. And, you know, we have our own professional associations saying, oh, no, you mustn't say anything, you must be nice. Time to stop being nice is my view.
Okay, thanks, Jim. I must say Cassandra Kardashian has a nice ring to it. But yes, look appalled. Okay, thanks, Jim. And I take your point that it's about popularising some of the social justice issues, which is really important.